Welcome back after a very, very short little break of changing of the guard. And we're continuing on budget adjustment, and we have Vermont Department of Health in to go over their budget. And this is always really confusing, which is Human Services actually has jurisdiction over most of Department of Health, but there's so much of it that interlaps with
It is
healthcare.
very hard to disentangle healthcare and human services. I completely agree.
Yeah.
So,
So,
and in truth, really what I was hoping to do is take this opportunity to introduce myself and tell you a little bit about me, what my experience has been so far and what some of my priorities are, having stepped into this. And that'll be much of what I talk about. So I think that's helpful regardless, just to do that with you guys. So anyway, nice to meet you all. My name is Rick Hildebrandt. As many of you know, I am a physician. I'm still practicing. I see patients on the inpatient unit at Rutland, and I've done that for 13 years. So inpatient medicine is my love. I've been in Vermont since finishing my residency in Dartmouth, again, 13 years ago. And when I started practicing here, there was a couple of things that were immediately apparent to me. One was that there were decisions that were being made at the time that there was not a single clinician at the decision table, and they were making some decisions that were confusing to me because of that. And it wasn't because they weren't invited. It wasn't that people didn't want doctors or nurses there. It's just that people weren't really raising their hands to join the meetings. Okay. There's not a lot of clinicians really just want to do clinical medicine. So I started inviting myself to a lot of meetings, and that found me on a leadership track at the hospital, which was not in my plan at all. I was planning to be a clinician my whole life, but I ended up in a series of promotions over the time I was there and into leadership and executive leadership positions. The other thing that was immediately apparent to me was that I can't solve the problems of my patients in the four walls of the hospital. They're bigger than me. They're bigger than us in that building. So I started working with local community partners first on very tangible hospital kind of things like readmission rates and ED utilization, things that I knew a lot about, and care coordination with our primary care physicians, with our area VNAs, the skilled nursing facilities, to just improve the care of patients, and that was very successful. But as time went on, I still saw the same issue where people would come back time and time and time again with the same problems. And it really boiled down to the social drivers of health were causing a lot of folks to need healthcare. They didn't have access to, and you guys know this more than most do, they didn't have access to transportation or to money or to food or to all the things that are required to be healthy in life. And as a result, they end up, getting chronic illnesses and getting hospitalized. So that led me to seek out different boards and commissions around the state. I joined the local designated agencies board. I joined the board of Vital. At that time, I was something called the CMIO, which is Chief Medical Information Officer. It's a really interesting job. It's the interface between EMRs and doctors, which is a challenging space to say the least, but gives you a lot of insight. And I have interest in technology and data. So. And I joined the Board of Medical Practice, and I served as their chair for 4 years, which was great to get into that sort of regulatory space a little bit and understand a little bit about medical regulation. Anyway, I was also the COVID czar at our hospital and got involved in that a lot, and enjoyed I was the chair of the infection control committee. And for a while I had said to myself, hey, if and when Mark decides to retire, I'll consider throwing my hat in the ring. And when he did, a lot of people sort of encouraged me to seek out the position, and I did. And after 6 or 8 months, I found myself here. It took quite a process to get through, but it's been a whirlwind. Since arriving at the health department, I've been really, really impressed with the caliber of the people that work there. I don't know what I was expecting exactly, but these are like phenomenally intelligent, incredibly caring individuals who they're driven so much by the mission of the health department. And that was really striking to me. I'm learning a ton. I'm learning that I have a lot more to learn. And I'm learning from the colleagues that I have at the health department who are really knowledgeable. So here's the vision, the mission, and the values of the health department. And I just put that up there to sort of share it with you and also say that part of the reason I also did seek out this position is right now is an interesting time in public health. There is an attack on science and on public health itself. And that felt like a calling to me. And this vision really did, and the mission really speak to me as well. And part of the reason I sought out this position. All right. So public health is a hard thing to define. I've certainly found that to be true. And in the health department, we use this scheme to try and define it: detect, connect, prevent, and respond. So as a tangible example, a number of months ago, we detected a number of cases of pertussis, which is whooping cough, in a school in Washington County. And we responded by providing the school community with the resources that they would need to help immunize or protect themselves with PPE. And we alerted the area healthcare providers to help them prevent the spread and share the knowledge. So sort of detect, connect, prevent, and respond is the sort of approach we use. And we do this in, yes, infectious diseases, but there's so many other places that the health department touches that I didn't know about, whether it's environmental health, school nursing, chronic disease, building healthy behaviors. There's so many different places that the health department does connect. That's not just the ones we hear about with Stellantis. So I often refer to this organizational chart just to remind myself of all the different areas that we are involved with. And we call this the chiclet map. And all the pieces, because the little things look like chiclets.
Oh, even like chickens.
Chiclets
See it.
that you should not.
I was gonna say that's to eat, right?
Right. So the
Chickens,
The health department has a wide range of activities, from very concrete clinical things like the Office of the Chief Medical Examiner, nursing home visiting, or the laboratory testing that we provide across the state. And then others that are much more community-based, like chronic disease prevention, health promotion, environmental health, which looks at water, air quality, and food safety. And thankfully, we have experts in all of these fields, because I am not an expert in all these fields, but we have incredibly intelligent, well-educated individuals who know a lot of stuff about these things. So if there's ever an area where you are all interested, I can make sure to bring the right person that can answer your questions.
Can I ask a dumb question?
No dumb questions.
Yes, there are, but sometimes. What's the difference between the green chiclets and the blue chiclets?
So yes, there's a different one that sort of separates them out. The green chiclets are in the commissioner's office.
Okay.
So, and the blue chiclets are within divisions.
Okay,
So
thank you.
that's what they.
I thought maybe it was like sugar and like.
Yep. What it is.
Like flow charts.
All right. So one thing that I felt is very strongly as part of my job is to ensure that I preserve the trust in public health. Vermont came out of the pandemic with a high degree of respect of the health department. That is not true everywhere. There are some states in our nation where the health department had a really bad rap after the pandemic. That was not true here. And I credit the health department and Dr. Levine for doing the work that they did to keep that. And I have to maintain that trust despite a near onslaught of attack against public health, which has been challenging at times. But we need to be the rock that people can rely on for trusted medical science and research information. That needs to always be the case. We always have to make sure we have accurate information that we're providing to the public. So that's something that I feel very strongly. The other piece, though, is trust is about relationships more so than authority. So having people in our local communities who know the individuals that work there, that know the staff persons, the school nurses, or the clergy persons, or the individuals in schools or in hospitals, in our local district offices and around the state, they can build those relationships and have that trust. And that is so valuable within the health department. All right, so there are a few issues that I wanted to touch base on that have already come to surface and will certainly continue to come to surface over the course of the year. First among them is immunizations. So with immunizations, there have been a lot of false claims and falsehoods that have been fueled by these changes that have been happening at the CDC. Just this past week, we've heard some pretty loud announcements around changes to their recommended vaccine schedule. And we have, for a long time now, for several months, been working with a large group of stakeholders within state government to ensure that regardless of what happens on the federal landscape, Vermonters continue to have access to immunizations, okay? And that includes health, that includes Department of Vermont Health Access, OPR, Department of Financial Regulation, and many, many more. And we've been working with you all and with other legislators to introduce some legislation to make sure that, again, Vermonters continue to have access to vaccines and that we publish the most up-to-date, research on what is effective. We're not.
And we're gonna do a flyover drive-through
Yes.
of the bill that Human Services has in their committee. We're gonna do that next week. We need to.
5:45.
Yes.
Were the pertussis outbreaks related to a lack of immunization?
Every case of pertussis was someone that was either unvaccinated or under vaccinated.
Thank you.
Three case.
Yeah. I can tell you I had whooping cough. So way back when they didn't give boosters, because we didn't know. So if you were old enough, it would wear off and it was awful. I mean, it was really terrible. Now, it wasn't deadly as a kid, at that age. As an infant, it could be deadly, but it
We're
was
supposed to get boosters for that?
Oh, yeah.
Oh, I'm sure.
It's in the tetanus shot. It's in the tetanus shot. But Tdap has it in it, but it's because you cough until you vomit.
Yeah.
And it's just awful.
I'm an anti-vaxxer now, so
Please.
let's not get into it today because we have a lot to cover.
Stop it.
I'm happy to talk about it later.
All right.
The doctor may convince me otherwise, though.
Take 5 minutes.
Okay, let's
Yeah, let's move on.
So the next one
forward to next week.
that has certainly come to light is around substance use disorder. This isn't a new problem we have in Vermont. And frankly, Vermont has done an excellent job at our response to substance use disorder. The hub and spoke model, I think, has been particularly effective. And I've seen that in my own practice, where 10 years ago, when I was caring for folks in the hospital, they were actively using IV drugs and had endocarditis or infections of the heart valves routinely. I am seeing so much less active IV drug use and more people who are in recovery, maybe with relapse, and you still, of course, see endocarditis, but it's dwarfed by the number of people who are in recovery or get in treatment and receiving Suboxone or methadone or some form of treatment, which is really, really encouraging. That being said, there's certainly gaps and challenges within our system. Recovery housing is a gap that we have for sure right now. There's a spectrum of care that we need for folks who need recovery services. They need hospitalization and acute services. They need residential treatment facilities. We recently worked with Valley Vista to open a lower intensity residential treatment facility, which is wonderful. And then recovery residences, which is that sort of longer term measured oftentimes in years, where people live and work with oftentimes peers who are in recovery themselves. The other piece about substance use disorder, though, is the landscape is changing. It's been heroin and opiates for many, many years in Vermont and around the country, and it's changing. We're seeing much more stimulant use disorder, cocaine, and unfortunately, we have seen some increases in methamphetamines, which is, in my assessment, the worst thing that humans have ever invented. It is just so hard to treat. It's so hard to help people who have meth use disorder. People can become very aggressive and violent when they're using it because of the stimulant effects. And my colleagues around the country who care for folks with this regularly, it's really harrowing, the stories that they can tell you. So it's not very high in Vermont with meth, but it is unfortunately increasing, and stimulants around the country are increasing as well as in Vermont. Polysubstance use, though, is also a significant challenge that we're seeing. So it's something we're keeping a very close eye on. We're changing some of our reports to show not just opiates, but also other drugs of abuse because of that.
Ellen.
Just a question.
Yeah.
I think I just saw something, supposedly the news. Drug deaths has dropped, but the drug use, meth mostly, has increased 23 to 25%.
Yeah.
So do we have medicine that counteracts that, or what's the reason for that?
So I don't know that I can speak to the exact reason for that. I can tell you there's no MOUD, there's no Suboxone or methadone for stimulants. Okay, so that's part of the challenge, that the treatment options are not the same. And an MOUD really has been a game changer in the opiate world. It has significantly helped. There has been a change, which is a good change, if you can see it that way, from IV drug use to inhalant drug use. Inhalant drug use, i.e. a crack pipe, is far less lethal than IV drug use, and it has less risk of infection. So I would, some of it may be fueled by that, but we definitely are still seeing a high number of overdoses and overdose deaths. A lower percentage of them are from opiate. All right. And the last thing that is very clear to me, a priority of myself, of the department, and of the state is around access to care. Healthcare transformation is something very near and dear to my heart. And this is certainly not something that is entirely owned by the health department, but it's something that I've been in healthcare for many years, and I've seen the challenges that we have. And I know the important work of this group and many, many others in helping with healthcare transformation and what that looks like. What I feel is very important is over the course of that transformation, we need to make sure we have access to our monitors. And that requires a lot of care and attention to make sure that these changes don't happen and the patients get stuck in the cracks, right? We don't want that. So while healthcare is not public health, there's not 100% overlap, access to healthcare absolutely can become that. So obstetric care, I think, is one that has been discussed a lot. And it's important that we continue to have access to birthing moms, both pre and postnatal, regardless of where you are in the state. Transportation is a huge challenge. As we talk about regionalization of healthcare, we need to have a rock solid transportation system. We don't have that right now. EMS does fall under the health department, and I've been working with our EMS team because that is absolutely something we want to help with to make sure that these efforts are going well. And then reproductive health care. This is a critical service, and it is protected by our Constitution. And there is significant concern on the federal level that it's under attack. So we want to ensure that we have access to care for all Vermonters. We know that I know for sure that change needs to happen. I can tell you, firsthand that we have massive changes that need to occur. But in that change, we do need to ensure that we have access for our folks in Vermont. Any questions for me? Otherwise, I would hand it over to Megan.
How many more slides do we have left? Because I don't see it online, and I'm trying to not ask questions if I see it coming.
This is basically the last, there's two more
I'm
slides.
gonna wait and then I'll ask at the end. Thank you. Yeah. If there's time.
I have a public health question, which may not be now, but I feel like it's half of Vermonters die of cardiovascular disease. So thinking about that and the approach towards that is something I'm interested in. So
Yeah.
when it's appropriate to think about it and talk about that.
Yeah, chronic disease prevention.
Is the prevention moving upstream? And I don't want to take time right now, but.
No, I completely agree with you. I'm just learning about the budget of the health department. And when you look at the cost of a disease like diabetes versus how much we spend to try and prevent it, it makes me baffled.
Yes.
Right? Because you're right.
Yes.
If you can prevent some of these illnesses, you can prevent massive costs. Now, listen, it's an investment in decades,
Right.
But it's still.
But it's a
very true.
conversation I'd love to have with you.
Absolutely.
Okay.
For the record, I'm Megan Hope, Financial Director at the department. Thank you all for having us. We're now into the numbers side of things. So our 2026 budget adjustment is rather small. We really only have two asks. The first, you might have seen in other areas of AHS, it's just a transfer of general fund and federal fund from the agency central office to departments for increased costs for our agency of digital services agreement. So you may have seen that before. Really the biggest piece of substance in our budget adjustment is a swap of funding due to the federal HR1 bill. We're asking for $300,000 that was previously in our budget as global commitment investment to be funded as general fund because HR1 put a 1-year restriction on Medicaid funding to Planned Parenthood for family planning services. So that is really the biggest piece of our budget adjustment.
What was this for to Planned Parenthood?
It's a
Grant?
Yep, it's a grant. We have it was a 2-year grant. It ends 6/30/2026, but usually, we've historically given out this money annually. And it's the funding is intended to support the administration, operations, and outreach family planning services that they do.
Wasn't. So I'm curious about the Agency of Digital Services.
Mhm.
And I see that it's net neutral to AHS, but not to you.
Yes.
I'm trying to understand how.
Yep, so the Agency of Human Services has the money that, the way we budget for these costs is the agency gets the money and then distributes it out to different departments based on utilization. It's for things like desktop support, those broader IT level services. So the agency kind of gets that initial pot of money and then distributes it to the departments based on.
They charge you for it.
Well, we get charged for it, but the money is first appropriated to the agency and then it's divvied out to the department. So that's really what this is doing. AHS will have a down, we have an up,
Okay.
if that makes sense.
What would happen if that went away?
The Agency of Digital Services
Yeah.
charge.
Or the Agency of Digital Services with that? I mean, that's a new department. And
Relatively newer.
how not, yeah, let me ask him.
Go ahead, Nolan.
I'm Gregory Nolan, I'll go to this one. ADS is like our digital, it was rebranded, not new.
Okay.
And it's like basically the state IT department. You get rid of the state IT department, you might as well get rid of our computer.
Okay.
Yeah.
But didn't
Go ahead.
we, it's always been around, but didn't we make some changes since I've been here where more of the work that was being done, maybe in the agencies, separate agencies are now all in ADS, which is why they're doing this, so now you all don't necessarily do the IT work.
The IT staff are technically employed by the
But
Agency of
yes.
Digital
Okay,
Services.
thank you.
You have to pay them.
Yes.
Rent on the IT.
Yes, this is our portion of the statewide
allocation.
IT support, yes, that we receive.
I know the health department is largely federal grant funded. I can't remember what your budget, but it's a big percentage of
Roughly,
federal funds.
I haven't looked in a little while, but usually about 50% of our funding is.
So I'm curious as to, with things that, we see in the news and stopping this and this grant cut out. How has any of this affected? And these are grant funds, which means that they're not appropriated through the legislature.
We receive spending authority from the
Spending
legislature.
authority,
Yeah,
but,
yeah.
so I'm wondering just how's it going?
Do you want to take that?
So Megan can maybe speak to the specifics, but we really haven't seen that much in terms of grants not being continued, which is really, really good. Now, there are some grants that are coming up that are going to expire that we are worried about. They may not renew, but grant payments have come through and really we haven't seen much change. Okay, now that could all absolutely change. And we don't have a budget yet, obviously, right? So that could have a significant impact. We are hopeful that it's all posturing and not a whole lot of substance, but we don't know until we see it.
I'm assuming you're not seeing a whole slew of new grant opportunities.
I mean, the only new grant opportunity is RHT, which is not a small grant.
Yeah.
Right? But outside of that, there's not new ones that we're seeing in the public health space.
Okay. Well. Doing well, and yes, go ahead, Brian, and then we're gonna finish up, so we'll get to the floor on time.
It's sort of distantly related to the presentation today, and ultimately, I'm hoping we can talk offline. But when Representative DeMar asked about stimulants, you said that there was no MOU,
MOUD.
MOUD.
Yeah.
Are you familiar with ibogaine?
I'm not up to the up-to-date research on many of those things. I've talked to some folks in the addiction field about what they're doing. And that's sort of the message that they gave me, like, it's not the same field. There's not a very clear, everyone should be on this medication. So,
Yeah, it's a one-time medicine anyway.
yeah.
Can we find a time to talk offline about this? Because I have a lot of information to share. Okay, thank you.
Absolutely.
Did I see you hand up over already my peripheral vision? No.
I do have a request,
Yes.
new commissioner, I'd like to let him know where we're all from.
Yeah, that'd be great.
Sure.
Sorry.
Where are you really
Yes.
from?
Since you-
Where I'm really from.
I'm so sorry, we haven't done introductions with you. I'm
Yeah.
thinking about introducing new members. Yeah, why don't you start?
Alan DeMar, I represent Enosburg and Montgomery.
Val Taylor, District 11. Wendy Critchlow, and I represent Chester.
Ryan Sheila, representing East District of Burlington.
Daisy Rebecca Winooski. And Alyssa Black, Essex.
Topper McFawn, and I'm from Barrytown, represent Barrytown and Williamstown, part of it.
Betty Powers, I represent Waterford, Barnet, and Reading.
Aaron leaders, Lincoln, Bristol, Starksboro, and Marsden, Addison 4.
Leslie Goldman, Rockingham, which is Bells Falls, Westminster, and Brookline.
And Lori Houghton, City of Essex Junction.
And welcome.
Thank you very
Yeah.
much. Appreciate that.
Good luck, good luck.
Yeah.
It's been great so far, to be fair.